Okay, I'm going through chapter 63, and we're going to cover the skeletal structures. I had already covered in part one the muscular structures, and we're still talking about musculoskeletal trauma here. All right, so let's start off with a fracture. Um, fractures are just a break in the bone. Um, they can be minor or severe. They can be open and closed. There's a couple different ways to classify them. It could be an open or a closed fracture. They can also be defined by the way that they are broken. Um, a complete break, if it goes all the way through the bone, where an incomplete break, obviously, it doesn't go all the way through, but maybe goes partially across, such is the case in like a green stick fracture or something of that nature. So you have open, you have closed, you have complete break, and incomplete break. You also have different ways you can identify them, like spiral or green stick, things of that nature. So these are ways to classify it. So you have a transverse version, you have a spiral, green stick, like I mentioned before, and communicative. Alright, so basically, open is where I've broken the skin. Closed is where the skin has not been broken, the bone is still inside. Um, the complete break is all the way through the bone, where an incomplete break is just partially the way through the bone. So again, green stick, that's an incomplete break. Communicated is where it's just straight shattered, and that's usually in a trauma. And you'll have tons of different pieces, so that's obviously a complete break. This would be categorized as an incomplete break. A spiral is usually seen in abuse, so that's a good indication of abuse because it's very traumatic, and it actually spirals down the bone. It is also associated in sports injuries, but again, it's very much abuse. Um, and then transverse is just like it sounds like transverse, a transverse line, so it's going straight across, and that's a complete break as well. Um, a displaced fracture is where the bone is completely out of alignment, um, and oblique or communicated is a is a type of those. So a displaced fracture, to break that down, displaced fracture, the communicated like is like you have all these bone fragments, and then the other part of the bone. And again, you see that in a trauma, and that is where the bone's not going to heal in the proper place. So let's say I displace this over here. All right, this at that point would be a displaced fracture because the bone is not aligned anymore. Whereas sometimes bone is still aligned. So this at this point it's not aligned. It has to be realigned in a displaced fracture. A non-displaced doesn't disrupt the perineum, is the outside covering of the bone. So let's say we're talking about a green stick fracture where we have like a slit in the bone. And a lot of times you see this in children, but let's say there's a break in the bone like this, but it doesn't disrupt the outside covering of the bone. That's a non-displaced fracture, and the periosteum, which is the outside, is not going to be disrupted. Alright, so that's still intact, and that's a non-displaced fracture. So displaced, non-displaced. Alright, so the manifestations. So the manifestations are really pretty simple for this, and you're going to see them across the board with many different things. And that's going to be, I'm going to write them over here. Alright, so that's going to be, manifestations are going to be edema, cyanosis, loss of pulse. And these are, again, are very obvious ones. Edema, obviously you're going to have, with edema, you're going to cut off circulation. So you might have poor capillary reflow, you might have a poor peripheral pulse in whatever extremity it was. So your pulse may be reduced. You might have, of course, you have swelling. With swelling, you're going to have heat, possibly pain, low pulse or lack thereof pulse, cyanosis because of the lack of pulse. These are all interrelated, so if you can think of one, then you can usually relate to the other one as well. Muscle spasm is one that you might not think of, but muscle spasms, where the body is reacting, and it's uncontrollable, involuntary muscle spasms, and it's caused by the irritation of that. Deformities as the other one, so that's really obvious. So if the bone is, bent a certain way and it's not supposed to be bent that way, then that's an obvious issue. These ones right here, these edemas, and I'm going to write it over here in blue. Edema, lack of pulse, heat, which is just a reaction to that inflammation process, pain, cyanosis, poor capillary refill, muscle spasm. You're going to see this throughout the entire chapter. So if you can relate back to those as far as manifestations, then it will make a lot more sense. Alright, so those are the ways that you can categorize the bones, and these are the manifestations. And again, I wrote those over to the side because we'll continue to refer to those. Alright, the other thing, bruising, obviously. And again, this is pretty self-explanatory, but bruising, which is fancily, again, me my spelling, cyanosis or bruising. Alright, confusion would be another one if it was to be a head trauma, or you would have lack of, there's some of the, where you would have an embolism, that might create a lack of oxygen to the brain, depending on where it goes. And obviously discoloration. Lack of movement, I guess, is another one, although that's pretty obvious again. So your range of motion will be impaired. Alright, so those are your, one last one, crepitation, which is something I failed to mention, and maybe not something that you would think of, but crepitation is that crunching together sound, or the cracking of bone fragments. It's not only audible but also palpable, so you can feel it. So the cracking or the crunching sound. Alright, so those are your ways of identifying it. Let's see if I can find it. Alright. Alright, so fracture healing. Fracture healing is going to be important. So fracture healing goes in set stages. Of course, you have the first one, you just have bleeding, and the actual state is fracture hematoma, again, bleeding. Alright, so at this point, this is the reaction of the initial trauma, where you're going to have bleeding around the surrounding areas, and it should turn into a clot within the first 72 hours. And again, this is fracture hematoma, as the name suggests. The next part is granulation, and we know we all love granulation tissue. Granulation is basically where phagocytosis starts to happen and the clot actually starts to form. You're going to have that hematoma turn into the granulation tissue. New blood vessels, fibroblasts, and a lot of the osteoblasts, which again, the osteoblasts, you have osteoblasts and osteoclasts and osteocytes. Osteoblasts are going to help make bone. So you're going to have a lot more osteoblasts in the area. And you're going to have the basis of the new bone, which is the osteo. So Alright, so granulation, again, you're going to have your phagocytosis, all the cells are going to start rushing to it, and that's where you're going to have the bones start to form, and the hematoma will become the granulation tissue. And you'll see a lot of the fibroblasts start to form a more structured area. Alright, next, the third part is, and then, sorry, I switched colors, caucus. Alright, the calculus, after we have the cells go over there, the phagocytosis that are eating dead fat or dead cells, then you're going to have the calculus which forms, and that is where the new bone matrix is formed. But it's just kind of irregular and just one big lump, and so you end up with a lot more bone than you might need there. And of course you need your calcium, your calcium phosphate, right? Calcium phosphate. And it's just a kind of a big mess of bone. You're going to have cartilage and osteoblasts, and obviously your calcium phosphate. This can be verified by X-ray. So if I were to draw this out, you have, this is your calculus, okay? So it's just a big mesh of bones. It's not all the way solidified or ossified, but you're going to have this in this area, and you can see this on X-ray. Alright, so 4. That's ossification. Ossification phase is the continuing formation of this calculus, and the calculus is going to continue to form until it starts to remodel, which is one of your last steps. So ossification, the calculus is becoming more solidified. It prevents movement of the fracture sites. At this point, your cast can be removed with a limited mobility. So cast removal is here, and it's just hardening that calculus, further developing it and preventing movement of the two bones. All right. Consolidation. What do we do when we consolidate? Well, we bring things together, right? So same thing here. Consolidation is the distal bone fragments have been diminished. All right. This is verified through X-ray as well as a bone reunion. So union is used a lot in as far as bone fractures go, but it just means the bringing together of the two bones. Okay. So consolidation is the bones are being brought together, and again verified through X-ray. All right. Your final phase is the remodeling phase, and that's where excess bone is going to be reabsorbed. It's the final stage, and union is complete here. So remodeling. And remember, our osteoblasts are making it, so it's our osteoclasts that are going in there and fine-tuning that area. All right, so that it's where it should be, okay? And it's releasing any unnecessary calcium phosphate in the bloodstream, which will either be, reabsorbed somewhere else or excreted. But so that's the remodeling phase. All right. There's several factors, of course, that will delay healing. That's going to include smoking, age. So obviously, a child's going to heal quicker than an adult will. You also have vitamin C deficiencies, nutritional deficiencies, lack of protein, lack of calcium and phosphate. Obviously, is going to be an issue, and your magnesium is going to be important as well. So several issues can delay that wound healing. Delayed wound healing or delayed union is the technical term. Delayed union is where you have an abnormally long healing time. So from the beginning you have your bleeding or your fracture hematoma. Then you're going to go into granulation, where you're going to have a lot of the cells come in, and it's going to form that osteoid phagocytosis. Osteoblasts you're going to see a lot here, and then you've got the calculus, which is the fibrous forming of that around the fracture site. And again, it's just kind of a matrix of stuff, not very organized. Ossification, you have hardening of the calculus, and the cast can be removed, and the fracture site should be fairly well put together. The consolidation is the final phase as far as your bones being brought together, and then remodeling is the fine-tuning of that rather large calculus that we started off with. So that is your stages of healing. Let's talk about issues that could happen. There's several issues, so don't think that they're limited to this, because we have several embolisms that can happen, fat embolisms, things like that. But so factors as far as delayed healing or healing in the actual fracture itself. Of course, you have delayed, and again, they're going to use the word union, delayed union, and that has to do with the protein of the vitamin C, or maybe immune compromised. There's several factors that could play in that. Non-union, the bone is not coming together. Obviously, you can verify that through X-rays or MRIs, CTs. Malurine, as it sounds, malurine. Can't say that word. Malunion, alright, is where it's improperly healed. So if I want my bones to come together like this, they might have come together like this instead, okay? So probably because of improper healing, weight bearing, things like that, not following what they should be doing with the healing, or not seeking treatment at all. The pseudo, this is pseudo arth, make sure I'm forming this right. Arthrosis. Alright, so pseudo means fake, and then arthrosis. Alright, so to break that down, it means fake. Well, really, we're talking about a fake joint. So what's going to happen here is that all of a sudden, these two bones that should be unioned, I guess I should say that word, instead they are creating a false joint, and you have abnormal movement in that bone. So it's a fake joint, essentially, is what it means. And it's at the fracture site. It's non-union because it's not actually together, and there's actual movement in the extremity itself. Aggravation is the same thing. It heals abnormally from the midline. It's just a type of malunion. So it's just a different type of malunion. But when it heals and the malunion is off the baseline or the midline of the bone, then that's referred to as aggravation. All right. And of course, you have refracture. So if I refracture the site, we know that the site is going to be weaker. You have the potential for refracturing it in the same spot. Myocystis, all right, ossification, myocystis, all right, this is bone being deposited in the muscles itself. All right, so again, break down the word, and you can see that it says you're going to have bone or calcium deposits in the muscles themselves. All right, so those are some of the issues you might have with fracture healing themselves. And I'm going fast because this is a rather large chapter. All right, so collaborative care for this, like I said before, you can diagnose this with an X-ray, CT scan, MRI. All right, those are how you're going to diagnose it. Fracture reduction. Fracture reduction can be closed or open. Fracture reduction, I'm trying to bring something together. And then again, you have open and closed. Obviously, open, as it might sound, is going to be I'm surgically creating the opening. Closed is I'm putting a boot on or a splint on that's going to create reduction between the two bones. You have the closed one, which is the skin traction, and then the open reduction. So closed, again, no surgical opening. It's a skin reduction where you're going to have a boot on or a splint on, some type of device where you're not actually putting pins in there. So not the same as open traction. So that is reduction. All right, so fraction reduction, open or closed. Fraction immobilization. Obviously, fracture, if I want to immobilize something, I can use a wrap, I can use a splint, I can use a cast. Those are just the immobilizing ways, or fixation. Let's talk about, I'll write this down. Fracture, immobilization. I mean, these are pretty obvious. Casts, splints, wraps, things of that nature. Anything to immobilize the joint, and usually it's immobilized above and below the site. Alright, the other one, you're going to have open, which is surgical debridement. So if I have an open fracture and I have the bone that's poked through, I run the risk, of course, of infection, which is going to be bad. And so you immediately want to give like a tetanus shot, antibiotics, and debridement. It's going to be really important. So that means that we're scrubbing everything out, getting everything out of there, to prevent an infection inside the bone, which can create big issues later, and you'll see that in chapter 64. Open reduction, or as I was, the closed reduction. Closed reduction is where we're going to have the realignment and manually applied splint. It's non-surgical, and again, closed means it's not open. Closed reduction. Alright, so let's say I go in and somebody breaks their arm, I put them under, and I'm going to pull that arm out and then stick it back in where it's supposed to go. So I'm realigning the bones, but the skin is still closed, which is of course the best probable thing you can have, because we don't run a risk of infection, have to give the tetanus shots, antibiotics. Of course you're still going to immobilize, but you don't run those risks. Alright, so this is a manually applied splint. Closed reduction is I'm realigning it under anesthesia because you need those muscles to be loose. Open reduction, of course, is a surgical insertion. Internal fixation is generally used, and we're going to see this in you're going to see this type of open reduction as we look at some of our other tractions. So, anyways, open reduction is going to be some type of surgical opening, and by reduction I'm trying to realign the bones, but generally they are going to use some type of fixator and that actually is something else. But just so you know, open reduction is I've surgically created an opening to realign the bones. Alright, traction is applied, it's a pulling force. You have either traction or counter traction, which is going to obviously counter traction is the opposite direction. And the point is of traction. Alright, so traction is some type of pulling force. So this is like, you can do it on the skin itself, which is a lighter weight traction. It's going to be 5 to 10 pounds. It's very short term. But really what I'm doing is I'm taking something and I'm literally pulling on it using some type of pulley system, whether it be, if it's a closed traction system, then I've got a boot or a splint on it, and I've got a weight attached to it. Alright, and it reduces the amount of pain, and it helps with realignment. It also allows for immobilization and range of motion. But the traction that's open is usually used for short-term use only prior to surgeries, things of that nature. And it's a lot smaller weights, like 5 to 10 pounds. As a nurse, of course, you want to make sure the weight's not on the ground. And then counter traction, like I said, is pulling the other direction. It prevents further damage from the soft tissue. So once you have a bone break, you have those sharp edges in there that will create a lot of skin damage and of course edema. And then you have your other issues that run along with the edema. So skin traction, like I just said, that's the tape or boot, but it's not open. So skin traction, close. Skin traction is an example of a closed one. So again, I've not made any surgical openings, but it's a boot or splint or something of that nature, and it's called skin traction. All right, again, used for short-term use. The Bucks traction system is the most popular in our closed. I keep saying closed since I got confused just now. Bucks traction is a boot that's applied, and it's especially used in hip and femur, and hip and femur fractures. In all scenarios, you need to be assessing for these things right here. You need to be assessing for your pulse. You need to be assessing to make sure that everything's got good blood flow, because if things don't have good blood flow, they die. Alright? Obviously, that's not great. So, make sure, and the other thing is assessing pressure points, because as we do these devices, pressure points. As we put on these splints and casts and brace and slings and all types of other stuff, we create pressure points. Okay, so pressure points obviously degrade skin integrity and you create open wounds, so that's not good. The skeletal traction is your open traction system, and it's Skeletal traction, sorry, um, is used for skeletal traction is used for longer term. This is long-term use, and you've surgically inserted pins. And again, you have the same with traction. You have pulling or counter traction. You have pulling the opposite direction. Either way, it's for alignment to reduce pain, provide intervention, and to immobilize and prevent further damage of the tissue. The skeletal traction, of course, if I have to get to your skeletal system, I have to make an opening, right? So they're going to use some type of pin and devices. The weight is going to go up here, and you're going to see this at 5 to 45. And again, you're checking to make sure the weight's not on the ground. Excuse me. Casts are casts are used to immobilize. They dry within 15 minutes. You're not supposed to put weight on it for 24 to 72 hours, but that's on doctor's orders. Avoid making dents in the cast. You're supposed to use an open palm when you make casts because any dents are going to create the risk for further pressure ulcers. So not only will you have a broken arm or broken leg, but now you've got a pressure ulcer, and we don't want that. So casts are obviously not supposed to get wet. You're not supposed to stick things in your cast. They have them in fiberglass, I can't say that word, fiberglass, and plaster, which is a little bit heavier, a little bit more cumbersome, and can't get wet at all. Neither of them really should get wet, but your fiberglass is a little bit safer to get wet. You also don't want to wrap anything in plastic for long periods of time because it can't breathe already. And if we wrap it in plastic, then it further can't breathe, and that's not good either for skin integrity. All right, so that's cast. Body jackets. Let's give us some of this information. Body jackets. Body jackets are just like what they sound like. They sound horrible, and that's because they're horrible. Body jackets are used for if you have some type of spinal injury, vertebral injury. All right, so body jackets are from the nipple to the pubis, and for vertebral injury. This, when you use the body, alright, body jacket, it's going to go all the way from the top, from your nipple line, all the way to your pubis, and that's going to immobilize your entire trunk. So with the things that have huge body casts like that, they leave an opening so that something can be catheterized or so that they can still, urinate. But so the body jackets are for vertebral injuries, obviously, but you really want to watch out for any type of compression with the superior mesenteric artery, because when you have that, you're going to have decreased blood flow to all types of areas. All right, so that's a very important area. You're going to have decreased blood flow, and patients will generally describe abdominal pain, abdominal upset, nausea, vomiting, abdominal cramping, decreased bowel sounds is another sign. So you really got to watch out for that blood flow when we're talking about this, because that can affect the entire abdominal GI system, everything. All right, anything below it is going to have decreased blood flow. So again, check your blood flow. Make sure that you're monitoring for bowel sounds here. Alright, because without bowel sounds, that means lack of bowel sounds means lots of bowel functions. Lack of bowel functions means bowel necrosis, right? So that's never a good thing. You also really need to watch for pressure points, like I already talked about here. You've got a lot of pressure points. Your iliac crest is going to be one of the areas with your body jacket that you need to assess more. Alright, so lower extremity injuries. And again, I'm moving fast. Lower extremity injuries. You have a long cast. A long cast is going to be when you've injured your knee or you have an unstable ankle, and they put a long cast which goes pretty much to the very top of your hips all the way down to your ankle. And of course, we can do shorter casts on things that are more structurally sound. So if you still have your knees okay and your ankles okay, then you can make a shorter cast. And the same thing is applied to arm. The long cast are again, if you break your tibia, your ankle, or your knee, short cast, stable ankle. You have to have a stable ankle for a short cast on your lower extremities. And you really need to assess for compartment syndrome. So I'm going to write this up here. So with any of your casts, you have the risk of compartment syndrome. Compartment syndrome is exactly what it sounds. Basically, we've taken something and we put it in a small little area when it has edema, and we run the risk of compartment syndrome where nothing can expand properly. And it may end up that they have to make an incision so that the limb can expand and the edema can expand. If it becomes very severe, then they may have to amputate the limb itself. And it's a fasciotomy where they do that slice so that you can have full expansion. Alright, so you really need to watch out for compartment syndrome. Again, edema, swelling, numbness, tingling, things of that nature. Neurovascular stuff. Alright, so the with lower extremities, you want to make sure you elevate for the first 24 hours, and you can apply ice to the outside of the cast, make sure it doesn't get wet. You're using that within the first 24 hours. You can also use a cool blow dryer for itching. But so lower extremities, make sure that you elevate the lower extremities to prevent compartment syndrome, because again, if we're standing, all of our fluid's going down, right? So we want to prevent that. Your hips, hip cast is also just as horrible as the body jacket sounds. It goes from your femur, it goes from the femur, and the trunk to the extremity, okay, above the nipple. So you're talking from the nipple to the base of your feet. All right, and we're generally using this in children because it's very hard for them to stay immobilized. They want to move, they want to get up, they want to go. So it's hard for them to immobilize because they don't bear weight on it for so long as they can get to the playground. So it's generally used for femur injuries in children, and it's going the whole length, including the extremity and the trunk. All right. And again, you want to be assessing, and with these body jackets and these big things, you have to give smaller meals because otherwise you're going to have an issue of abdominal retention. You also want to monitor for GI motility, things of that nature. External fixation. Let's move on. That's the metal pins inserted into your leg or your arm. I say leg, but it could be anywhere. External fixation is the metal pins inserted into the body, used in complicated and uncomplicated. Extensive damage where the limb may otherwise have been lost. Meticulous pain care is essential here, and you do that through half hydrogen peroxide and half normal saline. So external fixation, I can't remember what movie that is, but there's some movie where they have pins all over the person, some study. Anyhow, so here's your arm, poorly drawn, of course, and here's this cage or something with pins going into the body. And you might have seen this on a leg or an arm. External fixation is really it's where the break has been pretty bad usually. It can be uncomplicated, but the limb your key factor here is the limb may have otherwise been amputated. So you have a few options here. It's very important to take care of the pin sites because you run the risk of infection. It's going directly into your bone. That's never good if you have bone infection. Alright, so limb might be amputated, otherwise hydrogen peroxide with normal saline. So that's external fixation. Internal fixation is pins and plates, and again, that internal fixation goes back to where I talked about open reduction. When you have open reduction, you've made a cut in something and you did reduced it by aligning it, but most of the time they're going to make sure that that's a plate or a screw or something, and that's where you have internal fixation. So I've taken this external fixation and I put it inside the body. That's called internal, and that's where we have a bone and a bone, and then they've taken some type of plate and hammered it in. Alright, so that's internal fixation. Usually made of stainless steel. Either way, it's something that the body can accept. So that's their whole goal there. Drug therapy for this is going to be reduction of muscle spasm. That's other than your obvious inflammation, pain, things of that nature. And again, if it's open, you need antibiotics. You're going to need tetanus because you're on the risk of getting tetanus with that. But you also want to decrease muscle spasms. And some of your drugs that will decrease muscle spasms, and of course I have to put in my little paper here. Carcioprodol. Is going to reduce muscle spasms, and cytobenzaprine will reduce muscle spasm. I found this for translation. All right. So that's going to cover that. Now, next part is nutrition. And again, it's a long chapter, so and I'm going very fast over it. So some of the bones I won't even hit because the casts pretty much require the same type of care and assessment with the exception of the pelvic. But anyways, so nutrition, like I said before, it's going to be important that you have C. Vitamin C is important for healing. You're going to need protein. They're up in the protein to 1 gram per kilogram or per pound, not kilogram here. So vitamin C, vitamin B, vitamin D, obviously. For calcium absorption, you need calcium, you need phosphate, you need magnesium. All right. Of course, low vitamin C or low protein is going to delay healing. And again, smoking, because it's bad on everything, is also going to delay healing. Alright, so again, you're going to monitor for color, you're going to monitor for neurovascular, that means do you have feeling, is there tingling, is there blood flow, things of this nature. So neurons, nerves, and vascular, do you still have feeling to it, can you still move it? Compartment syndrome, you really need to monitor for that. Skin integrity, of course, because you've created all these little pressure points where you can have skin integrity breakdown. Making sure that they're getting proper fluids, unless it's counterintuitive to what they have. They have CHFs, and we're not going to put you on 2,500 milliliters of water every day. Plenty of fiber, because again, with a lot of these ones, you become immobile. When you become immobile, you have the possibility of bone breakdown and, of course, constipation. So making sure that the system's still working well and providing fiber, things of that nature. Bulky foods. And again, if you're in the body cast, you've got to get 6 small meals instead of creating distension, which is in itself is creating compartment syndrome. So, infection of the bone is going to be important. So infection, make sure that you're monitoring, especially open. Obviously, you're going to monitor for appendicitis and anything else that could create infection, open way to the body. Muscle atrophy, obviously, muscular atrophy by pure use of not using it. So like if I have a cast on one arm and no cast on the other, chances are when I take this cast off, the muscle itself is going to be smaller because it has been mobile. Foot drop is another problem. Foot drop is where you have the contracture of the Achilles tendon, which is another thing you need to assess for. Contracture over here. Contracture, so that's where, because something has not been used, it's actually contracted, and a lot of times you see it in the neck, it's a contracture. So contracture in the foot drop, so your foot's normally like this, and all of a sudden it becomes like this because the Achilles itself has pulled the foot down, and again, lack of use. So your nursing considerations for this, especially with contractures, isometric or exercise, changing positions and making sure that we're not creating pressure points. Stretching out the limbs, especially your Achilles, because you don't want to end up with foot drop. And you can put a block or a pillow there or something else. Don't massage muscle spasms. Alright. And I would have been tempted to do something like that. But you don't massage a muscle spasm because you can actually create additional muscle spasms, which is not helpful. Patient teaching, elevate, keep the cast dry. Don't stick stuff down your cast. If you have complications, if you have cyanosis, you have tingling in your fingers, you need to talk to your doctor. Elevate for the first 24 to 48 hours, and you can ice for the first 24 hours. All right, and again, through the cast, making sure the cast doesn't get wet. And like I said before, when you ice, you only do it for so long because it will have that paradoxical effect where it's actually not helping at all. Book says 20 to 30, some say 15. So But you do have to go through the class, so I think it would be safe for that. Do this one with 30. Anyhow, because you'd have to go through the entire cast. Alright, I've mentioned several times the tetanus, getting tetanus on an open wound, and that's because of your the tetanus bacteria itself. Clostridium tetani. Tetany. I got it right there. Alright, compartment syndrome. Again, you can assess for compartment syndrome by swelling, increased pressure, limited spacing, and a lot of times it's going to happen in trauma accidents, because if you have the more trauma you have, the more swelling you have, obviously you run the risk of compartment syndrome. Alright, oh, I forgot already. Parathesis, numbing of the area. So paralyzed, parathesis, numbing of an area, lack of feeling in an area, is another sign of compartment syndrome, but also something you should be assessing all the time anyways. Like I said, fasciotomy is where you cut open the skin to allow that pressure out. Venous thromboembolism, especially in big fractures of the long bones and lower extremities, and that is where you're going to have an embolism caused by a blood clot. It's a high risk after a long bone fracture, traumatic fracture, and again that could be coming from the blood around itself, the blood from the bone marrow, whatever it is, especially prevalent in hip fractures. Okay, so you really need to watch out for hip fractures there, for your venous thromboembolism. Venous thromboembolism. All right. So you really need to be monitoring for that, especially in the lower extremities. Lower extremities and high in hip. For a lot of times, prophylactically, you may get warfarin or Lovenox or something like that. Skids. Your stocking compression. Skids. So your stocking compression to prevent embolisms. Fat embolism is another thing that could happen, and that's going to be after a traumatic break. The mortality rate is high with this, and again, it happens a lot of times in long bone. The biggest thing here is that you want to detect it as soon as possible, and depending on where it goes, let's say it goes to the respiratory system, you're going to have, or it goes to the cardiovascular system, you're going to have tachycardia, anxiety, chest pain, increase in temp, decrease in your PaO2. Alright, so you might find your O2 goes down. So fat embolism. And this, again, could be coming from the marrow, or if you just break off and you have a lot of tissue damage, it could come from that as well. But either way, a decreased O2, increase in heart rate, tachycardia. They have a feeling of impending doom, which is kind of crazy. Impending doom. So the patient says, I feel like something bad's about to happen. Then that's a sign of fat embolism, which is pretty crazy. Cyanosis and anxiety. Obviously, anxiety. I mean, by pure nature, when you say embolism, you should be thinking of cyanosis anyways, because embolism is something that's blocking your blood flow. The result of that is cyanosis. So, and an increased temperature. That's another one. I actually didn't think about that, but increase in temperature. Okay, so fracture of the pelvis. Fractures of the pelvis are pretty serious, and they can be life-threatening, because when you have a fracture of the pelvis, a lot of times you run the risk of having other very vital organs being damaged. Okay, so fracture of the pelvis, you really need to monitor people. There's a high mortality rate with this, and that's probably in addition to the fact that pelvis fractures are generally in older populations. but it can be life-threatening, and you can create paralytic ileus hemorrhaging, eventually sepsis from having something ruptured, or from the lactation of the ureters, so things are starting to seep out as far as your abdominal cavities go, and that can create that sepsis. So, and obviously, again, damage to the vital organs. So the pelvis is really need to watch out for and be monitoring for abdominal pain, sepsis, increased septic manifestations, temperature, you know, blood pressure, things like that. But a lot of times temperature. So pelvis, really being careful with that because the mortality rate is high here. And watching for organ damage. Maybe you might have signs of renal impairment, your blood work, things of that nature. Right? So you could become septic here with the pelvic fracture. Hip replacement. And I realize we're kind of jumping everywhere. Hip replacement, in the event that you need the hip replacement, let's say you have an issue, it was very traumatic, you have a pelvis fracture, and then the hip replacement, something happened with the hip. You've got to be really careful with this, because otherwise it will pop out. So 90 degrees is a no, we can go. Alright, a forceful adduction, and abduction will come towards our body, abduction, we're coming towards our body, adduction will come towards our body, abduction will going out. But abduction, internal rotation. Alright, so rotating the limb, crossing the legs. Again, you don't want the hip to pop out. So you want to have a pillow between the legs. You want them to have a shower chair in there, and you want to have an elevated toilet seat, because that will put you back right at 90 degrees if you sit on the toilet seat. So you want to have an elevated toilet seat, and the rested position is elevated. You also want to turn them onto their good legs so that they can put weight on their good legs. Putting on shoes, which you don't really think about, but when you put on shoes, you go from a standing position to bending over like this, which again is going to put that hip at risk of popping back out. So anything that creates a lot of tension and makes that the socket actually want to pop out, right? Because there's not a whole lot holding it in after a hip replacement. So crossing your legs is a no-go. Putting on your shoes. And chairs should always have arms so they can push off of it. So again, the chair should not be at 90 degrees. The chair should be slightly reclined like this, so that they can, and also so that they can push off of it. And this is our last part here, is joint surgeries. So synovial oscopy is. I can send this around. Alright, synoviectomy. So basically, it's the removal of the synovial fluid. You obviously can't really, you can't get rid of all of it, but this is because of rheumatoid arthritis. By decreasing the amount, we can decrease the amount that the body is trying to attack it, and decrease the pain from that, swelling, and increase mobility. It's just removal of the synovial. So if you break down the word again, then you'll see that it makes sense. Alright, osteotomy. This is a slice or removal of a part of the bone in an attempt to realignment, or return it back to a regular position. The debridement, again, very important in open fractures. And it's the removement of debris or bone or anything that can cause soft tissue damage. Arthroplasty is reconstruction or replacement of the joint. And a lot of times it's going to happen in hips, it can happen in knees, it can happen in fingers, it can happen in a lot of things. But arthroplasty, alright, replacement of or reconstruction of a bone, or I'm sorry, of a joint. Alright, so that summarizes chapter 63.